All right. So thank you everyone for joining. My name is Janae Rasmussen, and I'm a third-year orthopedic surgery resident in Modesto, California. I'm really grateful for the Student American Osteopathic Academy of Orthopedics, who just had their meeting last week down in Texas. And then obviously the incredible OrthoLink Scholars team here. We have Laura, Alyssa, and Rachel. So thank you all for taking the time. So this talk is going to be short and sweet, and the goal is to give you the information that no one tells you as a medical student. It's not going to be on your boards, and yet the implications of what is being discussed is so important with how do you navigate an operating room. I recently obtained my fluoroscopy license for the state of California, and with that, I learned all these basic principles that I wish someone would have told me in advance. So that's the goal of today. If you have questions on anything, please feel free to put into the comments and I'll address them at the end. But otherwise, the goal of this talk again is to just go over the high level key takeaways to help reduce radiation exposure to yourself and also to your patients. The information in here is primarily from the state of California's fluoroscopy license book, which is about 178 pages long. I distilled it down to what are the key things you want to know. And then there's some other takeaways here from recent published articles and then other radiology resources. So the reason why radiation safety matters is because if you're going to be pursuing a field, whether it's GI, interventional cardiology, orthopedics, you're going to be exposed to a lot more radiation. And with that is going to be your increased risk of different side effects. So one of the most common associations is actually the risk of cataracts. I personally know several attendings who have had cataract surgery into their 50s, and a lot of that is attributed to the fact that they didn't know to even wear radiation safety glasses, and that certainly wasn't part of their training. So that's becoming a lot better, but knowing that your risk of cataracts is significantly higher if you are exposed to radiation long term. Another complication is when we think about malignancy, such as cancer. I'll talk a little bit about breast cancer specifically in women in orthopedics, but unfortunately, a lot of different cancers, including those that are benign, that are oftentimes like within the hand, where people put their hands and get lots of radiation, or it could be things that are a little bit more insidious, such as breast cancer, lung cancer. All of those have a higher propensity the more radiation that you're exposed to. And additionally, there are complications when we think about functions with your immune system, which can disrupt your white blood cells, your red blood cells. And so while you might have short-term effects of increased dose of radiation, more importantly, the goal of this talk is to think about 30 years down the line when now you're an attending physician, you've been doing this for a long time, and really kind of kicking yourself that you didn't start to be aware or make any changes earlier on when you're a medical student and as a resident. So the big takeaway is the more cumulative exposure to radiation that you get, the higher your risk of developing issues. So one of the important takeaways is that an estimated 50% of radiation exposure from diagnostic x-rays can be eliminated without compromising patient benefit. And so the point of that is if we all are cognizant and take steps to help reduce patient or improve patient safety and reduce radiation exposure, we can continue to have good x-ray, good quality of radiographic imaging while still reducing the overall amount of radiation. So one of the terms that they utilize a lot is called ALARA, which stands for as low as reasonably achievable, which means that you want to make sure that you get the images or imaging that you need to get the appropriate diagnosis or whatever you need to work up a patient, but you're trying to do it in a way that you're giving the least amount of radiation exposure that's necessary. So I mentioned women in orthopedic surgery with breast cancer, and this was something that last year as a second year resident, I came across a article that was talking about how women in orthopedic surgery and neurosurgery are associated with 4 to 5 times higher rates of breast cancer than the average woman. Now, there's not a lot of female orthopedic surgeons in general, so this was a pretty intriguing study. And essentially, what they found is that women that are in fields such as orthopedic surgery that are exposed to a lot of radiation, we tend to not have good coverage for the axilla region, and that puts us at a much higher risk of breast cancer. And most commonly, breast cancer is in the upper outer quadrant. And so it is super important, especially if you are a female, to be really cognizant about how you're wearing lead and your body positioning to help reduce your risk of getting breast cancer. So when we think about factors that increase radiation dose, so one of the basic things is stand farther away from the patient. The closer that you are to standing to a patient, the more radiation you're going to receive. On a few slides, I'm going to talk about how the fluoroscopy machine works, where the radiation comes from, how should you know where to stand. But one of the main takeaways is that the machine itself is always going to be facing the patient when we're talking about fluoroscopy. When it faces the patient, that patient now becomes the primary source of radiation scatter. So what does that mean? On the image on the bottom here, this is depicting what's called Compton scatter, which is in the simplest of terms saying that if you have radiation and it hits some electrons and it basically the high energy photon then hits electrons and those electrons basically scatter off. When it does that, it basically causes that energy. So all of that excess radiation energy to now scatter. And that's what causes most of the radiation exposure to those that are in the room. So most of the exposure, just to recap, is going to be not just from the fluoroscopy machine or the X-ray machine, it's more so coming from the patient. So the farther that you stand away from the patient, the better. In addition, there is a term called collimation. So collimation is if you imagine that you're taking like a photo. And what you're trying to do is you're trying to eliminate taking photos of anything that's unnecessary. So you're really trying to hyper focus what you're taking an image of. That's collimation. And this is a few simple things where if you tell like your X-ray tech or whoever's taking your imaging, hey, make sure you collimate, that's literally a few seconds of them just making a few adjustments, and you've dramatically reduced the radiation going to the patient and therefore the amount of radiation that's being scattered. Another important consideration is thinking about fluoroscopy time. So for those of you that have been in the operating room and you've been in maybe like a big acetabulum case or a really big procedure, if you get to 5 minutes of radiation dosage, then basically you're going to hear this like little alarm that comes from the machine. And this is a standardized protocol. And what it does is it basically helps alert to everyone in the room that, hey, this has now reached 25 rads of radiation. And so when you think about how can you reduce exposure to patients, try to be very efficient with how you're navigating, taking different imaging, making sure you're not taking a bunch of shots when maybe you can be a little bit better with your initial alignment before taking a shot or readjusting. And really remembering that, again, you being close to the patient and having increased fluoroscopy time are all going to be important factors. Another consideration is lack of radiation protective gear. So I'm going to show some photos later on about what that looks like. Most commonly, what people will wear is thyroid shield, and they'll oftentimes wear like a lead apron. There is a lot of male orthopedic surgeons, and I say a lot because there's 6 of them that I have worked with, starting as a medical student, that only wear a thyroid shield, and then they'll wear like a lead skirt. They wear nothing to cover their chest. And several of these were orthopedic surgery attendings that did a fellowship in trauma, and they still don't wear lead properly. And so I'm telling you this because I remember the first orthopedic surgery rotation that I went on, it was with the trauma surgeon who wore lead like this. And as a third-year medical student, I thought, oh, well, maybe it's not that much harm to, expose the chest because the surgeon's doing that. So I just want to make sure that people are aware that there are going to be bad examples. And so to really empower yourself to not only take your education for yourself, but also to help teach other medical students and really help make sure that people are aware of the cumulative effects of radiation. Again, unfortunately, this is not something that's taught in standard training for medical students. And even in orthopedic residency, if you're in the state of California for residency like myself, you have to take the fluoroscopy state exam to be a fluoroscopy supervisor. That's not the case with every state. So there's a lot of orthopedic residents who don't get this education and therefore become an attending and don't understand these basic implications. Another important consideration that increases radiation dose is magnification mode. Sometimes we go on magnification for certain parts of an orthopedic procedure. Some of you, if you've seen like femur intramedullary nail or tibia intramedullary nail, you might have seen us do like the perfect circles technique. For the sake of time, I'm not going to go into the details of that, but essentially there are reasons that we might need to magnify an image. But when you magnify, that is going to be increasing the amount of radiation that is going to be provided, typically about 4 to 6 times greater. Another consideration is when we think about room lighting. In orthopedics, it's really hard to operate oftentimes on open procedures and dim the room lighting. In arthroscopy, that's a different story. But there are considerations for if you're going to be, for example, in a cath lab, being in like a GI, doing like an enema or something like that, that there are a barium enema. There are ways that you can decrease room lighting to help you better visualize what's going on the screen, which should be able to help you reduce the amount of shots that you're taking. Another important consideration is live fluoroscopy. So oftentimes when we're taking an image around a joint, for example, we're fixing like a tibial plateau fracture, oftentimes we'll say go live, and what we'll do is we'll move the joint around as we're taking images. And that helps us be able to gauge, are there any screws in the joint? Is the joint alignment correct? Is there any mechanical blocks? So there are uses for when going live is appropriate. But the point being is that if you are going to go live with taking fluoroscopy, make sure you have a good reason, make sure everyone in the room is ready, make sure your, x-ray tech or whoever it is that's taking that shot stops when you tell them to stop, etc. And then we'll talk a little bit about this in a second, but more patient mass means that you have more photons and more energy. So if you're working on a 4-year-old kid and you're working on a both bone forearm fracture, that's going to use far less radiation compared to if you're working on a 250-pound male and you're doing an acetabulum fracture. So always just being mindful that the greater the patient mass, the larger the patient, that will often increase the amount of radiation that you, and then that's something that you'll want to be mindful of, is that
I told you I was gonna. You're gonna say you have to go get.
that patient's not only getting more radiation, but then everyone else in the room is getting more radiation because of the scatter. So I touched a little bit about tissue properties. So I just want to recap that point here, is that denser tissues are going to need more photons or more radiation to penetrate. So I'll talk a bit about extremity x-rays versus like something like a chest x-ray. And again, if you have a patient that has a thicker body part, so for example, if you have a patient that's morbidly obese and a really thick thigh and you're trying to get a femur x-ray, it's going to be way more challenging to get good imaging compared to if you have someone that, isn't obese or, is a thin, geriatric osteoporotic female, then in that scenario, you're going to have to use a lot less radiation. And then again, the more body mass, the more radiation you need, and therefore the more that's going to the patient, and therefore more is scattering off the patient. So I want to touch on some of those basic parameters. This is not something as a medical student you'll need to know. And even as a resident, it's not something that you're necessarily dictating what's the MA or what's the KVP, but it's something to be aware of because this is what your fluoroscopy technicians are going to be adjusting and helping maintain. So MA stands for milliamperage, and this is basically the density. And so the simplest way to think about this is the heavier the patient or the bigger the patient, larger the patient, the more mass that there is, the more MA that you need in order to image that body part. And so this is really dictating the X-ray beam quantity. So looking at the number of X-rays in the useful beam. So this image on the bottom here helps depict that if you use more MAs, meaning you're giving way more radiation, you're going to get a clearer image. So it's always a balance of you want a clear image, but you also don't want to give so much MA that now you are giving an unnecessary amount of radiation. So it's always that balance of getting a good image, but also trying to reduce the amount of radiation. So again, that comes back to that concept of ALARA that I talked about earlier about trying to give the lowest reasonable amount. So I brought up the point KVP a few times, and this is something that confused me quite a bit with studying. So I tried to simplify it as best as possible. So KVP stands for kilovolt peak. And what this is it's basically looking at contrast. The simplest way to think about that is that if you have an increased KVP, you have stronger X-rays. What that means is your X-rays are so much stronger that they can penetrate more. And by penetrating more through the body, you get brighter images. And with brighter images, you get lower contrast. So for example, in a chest x-ray, these patients are going to typically need a higher KVP. And this is because the radiation needs to penetrate through denser areas of the body in order for you to get a clear image. This is in contrast to an extremity x-ray, where you're not having to image through lungs, heart, etc. And this one, you're going to utilize a lower KVP. So this is going to allow for more x-ray absorption. Less is going to penetrate through the patient. And when you have more of that x-ray absorbed, that's going to allow you to better see more variation, meaning more contrast on the, bones or whatever part of the extremities that you're trying to see. So again, with KVP and MA, if there's nothing else that you take away, just remember that the more mass that a patient has, the more radiation you need to give. And that if you have a patient that you need to use like a chest x-ray or something where you need to penetrate through more tissue, then you're going to need a higher KVP. So again, higher KVP means more radiation goes through the patient, so less absorbed. And when more goes through the patient, you get more Compton scatter, so more exposure to you. So once again, coming back to that key principle is standing farther from the patient, decreasing the amount of radiation time, and giving the least amount of radiation that is necessary while still maintaining the quality imaging that you need. So I just wanted to put up a few different tables that I've had memorized. To be honest, I've long forgotten since finishing my exam. That was basically looking at different types of patient dosages with different X-ray exams. I just want to put up this for context. I think a lot of people don't realize, for example, how much more radiation comes from a CT versus an X-ray. So for those of you that maybe you go into emergency medicine or go into orthopedics and you're going into a field where you're going to be ordering CTs, always make sure that if you are ordering an image, you have a thought process as to why you're getting that. Because, for example, a CT scan, it's not insignificant the amount of radiation that you give to someone, especially if you're getting like a pelvis CT. And so I just finished like my pediatrics rotation, and there are some scenarios where we would get CT scans, but most of the time we'd be getting MRIs in kids due to the significant amount of excess radiation from a CT scan. So just being very mindful of when you're ordering a test, think about what's your reason and is the result of that going to change your management? And then again, here, I just wanted to highlight that there are limits for occupational workers. Most of the limits that they have here, no one gets even close to that if you're following appropriate radiation safety protocols. So this is not something where you should necessarily be concerned that you're getting too much radiation. But again, if you're doing this for years and years and years, that cumulative effect can certainly add up to getting complications such as cataracts, malignancy, et cetera. So I wanted to touch on a recent update on shielding. So this was published about 2 years ago. And basically what they found is that when you put on like a thyroid shield on a patient when you're going to do an exam or something else like that, that it actually may end up with more radiation. And so there's a trend in medicine to stop putting on like gonad shields or lead aprons on patients. Let's say if you're taking like an extremity X-ray, more and more studies are showing that the shields may actually increase radiation exposure because they might be blocking the type of imaging you're trying to get. So now you're getting an additional X-ray. And the other thing to consider is that on these different fluoroscopy machines is they have what's called AEC or automatic exposure control. And this is a way for the machines to help with modulating the amount of radiation, the MA, the KVP that you're getting for a certain shot. And so what they've found is that when you shield patients, that oftentimes can alter the AEC and result in higher radiation. So again, this is just something to be mindful of for you where you're shielding, but you'll notice that there's still discrepancies and more to learn about should we be shielding patients if we're getting, an X-ray, and what we should be doing with that. So I want to touch on lead aprons. So it is very, very common for lead aprons to not be worn properly. And I can speak to a lot of like the medical students that I'll work with, and especially those that are maybe more on the petite size that don't fit lead. And as the image in the center there shows, is that they'll oftentimes have the lead that's hanging off their shoulder. And oftentimes you'll notice like this thyroid shield, they'll wrap it around, but it's not actually covering the thyroid. It's basically like sitting down here. And so these are little things that you can help point out to other people and teach them, especially if you're going on audition rotation with, a new student. That's certainly a way you can help them out. But it's really important. The image that I have here on the middle, I see people all the time, attendings. I see like scrub techs. I see people that are wearing lead like this. And while you may think again, oh, it's just, we're taking a few quick shots, no big deal. the cumulative exposure is what is so important. So you want to get into good habits early and make sure that you're educating other people. And so in general, a lead apron, it covers the vast majority of your bone marrow. And all you need is a 0.25 millimeters of lead to help reduce the vast majority of radiation to your core, to your pelvis. With that, a lot of people will have lead that's like 0.5 millimeters. My lead personally is 0.5 millimeters. But my point being is you can have a light lead and still get a lot of great coverage. So lead vest and skirt, I talked earlier about how I've seen quite a few people in orthopedics where they just wear the skirts. They don't wear anything around, the chest. They just have the thyroid shield and skirt, and they are getting radiation to their chest area, to their abdominal organs, to, pretty high amount when you think about the cumulative effects. So when I started residency, I purchased the lead vest and skirt. It was a little bit more than like my program's budget. And none of my other residents have purchased that. But the reason why I did was because I had learned about the amount of increased radiation and especially how most lead, especially just aprons, does not give adequate coverage for females. So for me, it was worth, the extra like $200 outside the budget, knowing that long term, this is a worthwhile investment. So as a medical student, you're not, likely going to be purchasing lead or anything, but it's an orthopedic residency. Most programs will have like a budget to help you. And so I highly encourage you to really be cognizant that even if it's a little bit more money, I highly recommend getting, the lead vest and skirt, especially for those of you that are female. It really, honestly, it doesn't weigh that much more. It takes a little bit, like an extra few seconds to put on, but it's really not bad at all. So this recently came out. This was she's a breast surgeon that created this BAT breast axle and thyroid coverage. I haven't personally seen anyone wearing it and haven't purchased it myself, but it was designed as a way to help reduce uh, exposure of radiation, particularly in the axilla region, to help reduce risk of breast cancer. So with that, one of the obvious barriers, especially in orthopedic surgeons, is you're maneuvering around, you're getting sweaty. So I don't know how well this will likely work in that scenario, but potentially for those of you, if you go into a field such as, emergency medicine or interventional cardiology, where you might be doing a little bit more like standing maneuvers, then this might be a really good option. So there's a lot of new technologies coming out on the front line because of how, significant the accumulated cumulative dose of radiation can be. So I want to also touch on lead glasses. So lead glasses, they are a little bit heavier compared to normal glasses. And really, you only need 0.25 millimeters of lead equivalent glasses to get rid of most of your radiation exposure. I bought lead glasses when I started residency, but I didn't understand that there's a lot of excess scatter. And so the ones I bought basically only cover the front and there's no side shielding. So what I encourage for all of you is that if you are going to invest in lead glasses as a resident, get stuff with side shielding because a lot of the radiation is not coming straight at your eyes. A lot of it is bouncing off and getting into your eyes. So getting side shields is very helpful. There's been a lot of literature to support this as well. So I want to touch on patient and fluoroscopy positioning, and I have a few slides here following to help really hopefully ingrain that in your head. Feel free to take screenshots to highlight. Remember that the closer you stand to the patient, the higher the radiation. When we're thinking about fluoroscopy positioning, there's two basic main components of the machine. So with that, you have the image receptor, which is basically when the radiation touches the patient, it then goes on to the receptor. So the receptor is what's taking in that data. And what you find is that if the receptor is closer to the patient, that's going to give you better image. And if you're standing by the receptor, that gives you less radiation. And I'm going to show that in some images coming up to help that make a little bit more sense. But my point being is that imagine if you have the imaging receptor and the patient's far away, all that radiation that's coming and now hitting the patient has a bunch of distance to go to get to that receptor, compared to if the patient's close to the receptor and then the radiation comes in, there's a lot less scatter because more of that radiation that hits the patient goes onto the receptor. So this is something just to be mindful of when you're taking x-rays, is how can you reduce radiation not only to the patient, but reduce scatter and that to the room. So in this image here, what you can see on the left-hand side is kind of the ideal situation, which means that the X-ray beams are coming from the bottom and it's hitting the top of the table and it's hitting where the top of the table where the patient is. Remember that the patient's going to be the main source of that radiation scatter. And then the receptor is on the top. So what this is depicting here is the red arrows are depicting the radiation, that's coming up, and then the yellows depicting that scatter. What this is showing is that even though this person's standing close to the patient, most of that radiation is hitting the patient and bouncing down and hitting the floor. Contrast that to the right side. This is where the image receptor is on the bottom underneath the patient, and the source of the X-ray is coming from the top. Now all that radiation depicted in red is hitting the patient and then bouncing off and scattering around the room. But this time, instead of it scattering and hitting around the floor, it's now all around the room and more likely to hit individuals in the room. So again, this image here is just helping depict that, again, with the detector being what's going to be processing all of the imaging, and then the source is the source of the radiation. So in this image here, this is highlighting that a good example where the radiation is coming from the bottom, hitting the patient and the table, and that now scatter is now hitting around the floor, et cetera. It's not bouncing around the room as much because of the position of the machine. So these are some images that I took just to kind of help depict that, and hopefully this will resonate with you a little bit more because I know this can be a little bit confusing. So on the image on the left here, this is a good example. So let's say you're in the operating room with your orthopedic attending and they position the C-arm like this. What that means is that at the bottom is where the radiation is going to come from. The patient is going to be on a table that's going to be between where the radiation is coming from and the image receptor. So image receptor is at the top. And then at the bottom here is where the radiation is coming out. So what that does is that when that radiation comes from the bottom and hits the patient, now that is going to be bouncing down away, which is going to be helping to reduce the overall amount of scatter in the room. Now contrast that with the image on the right. There are some scenarios where maybe the attending will want to do like an extremity, like a medial epicondyle, for example. And so they basically use like the C-arm as like a table instead of like the hand table. And so they'll put it onto the table like this. Now the problem is you are dramatically increasing the amount of radiation exposure based on how you are positioning. So now in the scenario on the right, you have the image receptor on the bottom and you're having the source of radiation from the top. So now the source of radiation from the top is coming down, hitting the patient, and then it's scattering around the room, right in your direction, right in the direction of your nurses, etc. So this is a very simple, basic concept where if you can remember what is the receptor, and then, the fact that if you're standing on the side of the receptor, that's going to be helping you to not only reduce your exposure, but also helping reduce exposure radiation to the rest of the room. So this is an image helping depict that as well. Oftentimes when we're using fluoroscopy like C-arm in the operating room, we'll be having the C-arm like either flip so that it's coming like from an A to P view, or sometimes we come from like a lateral view, depending on what you're imaging. So in the image on the left here, this is a good scenario. This is where you're standing on the side of the image receptor. The patient's in front of you, the image receptor is in front of you. That image receptor is not only absorbing a lot of that radiation, but the patient's scatter from that radiation is going back away from you, the vast majority of it. Contrast that to on the right side, where sometimes you are going to be in the position where you are putting in screws or putting in implants, and you're standing on the opposite side of the image receptor. Every shot that you take, you are now getting all that excess radiation that's bouncing off the patient. So this is something that is so simple once you just identify, what side is the image receptor on, and remembering that you want to be on that side. And if you can counsel other medical students and other people around you, you can also help them become more aware about safer positions to stand. So when I have like an auditioning medical student, I'll normally have them like either stand behind me, or I'll try have them stand like on the side of the image receptor, even if I can't be on that side. Just again, we should all be looking out for each other and how can we be more safe with reducing radiation. So another key point that I want to bring up is some of you might have heard of mini C-arm. I have had many people in orthopedics tell me mini C-arm means less radiation. So I have seen plenty of people who, when we're doing a hand case or using mini C-arm, they don't wear lead. However, mini C-arm is actually a lot more radiation than big C-arm. The reason is that mini C-arm has a higher entrance dose of radiation, and because of that, you end up getting typically much improved image quality. And it's a lot less bulky, so they love using it in things like hand surgery. You can easily bring it in, bring it out. Most of the time, you don't even need like an X-ray tech in the room because you can just press like the foot pedal and take imaging. So mini C-arm is great. But it is so important to recognize that if you are using mini C-arm, you are exposing your patient and yourself to more radiation. And it is so important to make sure that you are wearing lead. Like I said, I have known fellowship trained individuals who don't wear lead when they're around mini C-arm because they think that it is less radiation. It unfortunately is more. Oftentimes it's quoted to being around like 50 to 70% greater than standard C-arm. And especially if you're going to do live images, so you're taking images of the hand and you're moving the joint like you're doing a distal radius fracture, that live image is going to have way more radiation than if you were doing a live image on a big C-arm. So just a few last important considerations. When we think about like pregnancy or women that, are pregnant and we're trying to reduce the amount of radiation, the most important time frame is the first 2 to 8 weeks of pregnancy, which is often when most women don't know that they are pregnant. This is the reason because that's the time of organogenesis, and so that's the most sensitive time for a fetus. And knowing that just 50 rads of radiation can cause an abortion of a fetus. On the image on the right here, I just put in some of the generalized radiation limit dosages, at least for the state of California. Um, Again, in general, it is very rare to be exposed to the amount of radiation that would cause you acutely to have radiation sickness or to have a lot of acute side effects. But it is important to recognize that all the things that we talked about today can ultimately lead to you having a decreased risk of cataracts, a decreased risk of different complications, decreased risk of fertility issues, breast cancer, etc., if you utilize this advice. So in summary, the cumulative effects of radiation increase your risk of cataracts and other issues. So it is very important that even right now, as a medical student, that you start to think about these things and how can you navigate around an operating room. Stand farther away from the patient, stand farther away from the X-ray source, stand near the image receptor. Remember that the patient is the main source of that scatter of radiation. Talk to your X-ray technician about collimation. Think about taking that image and you're kind of like zooming in on that image, so you're only taking X-ray photos of stuff you really need. And by focusing that image, by collimating it, you're not wasting radiation taking images of things that you don't care about. So collimation is simple, easy. Just use that word, and I guarantee you'll impress an attending on audition rotation. Wear your protective gear at the bare minimum. Wear a thyroid shield and wear a lead apron. If you can, I highly recommend wearing the lead vest, lead skirt. But again, sometimes they are perceived as too bulky or you just might not have access to them. If you have the ability to get radiation glasses, most of them are like oftentimes like around like $100, $200 unless you get like really expensive brand. If you are going to do that, look for ones with side shields. Avoid magnification as much as possible. Decrease room lighting if it's appropriate to help you better visualize the screen and not be constantly having to zoom in and like looking at the screen because the bright lights in the room are distracting you. Remember that mini C-arm does not mean less radiation. And your radiology technicians, nurses, etc., a lot of them already know a lot of this information and just haven't had the chance to really share it. So don't feel like shy about asking radiation technicians about this kind of information. And what I hope all of you do is on your audition rotations, share this kind of information with other people. I think if you did like a little mini presentation for like at the end of like your rotation, that would probably be something that most programs, like the residents, probably don't know much about, and they'd probably be pretty impressed by you by doing that. So I hope that you all learned a lot through this. And if you have any questions, feel free to let me know. Um, any questions in the chat?
I just had one little question. When it came time for purchasing your own lead as a resident, you mentioned that your program provided a certain amount of funds towards purchasing the lead. So anything, because you chose something that was a bit more coverage, it came out of your own pocket, right?
Yeah, so I think it was like a $700 stipend, and not all programs do this. My program's very generous, where most of the residents with just the thyroid shield and then the lead apron, they had it all covered. But I think mine was close to like 900 to get it with the full vest and skirt. So I paid about $200 out of pocket and then had the rest reimbursed. So that's something too that you should consider when you're looking at programs going on auditions is really asking about things like education fund, funds for things like surgical loops. My program, they pay for your lead, they pay for your loops, and it doesn't come out of your education fund. We also make sure like your board exams for like Comlex, any study tools that you use, that also is paid for and it's not coming out of your education fund. So just something else to be aware of when you're looking at programs because those costs really can add up. Even things like your DEA license to be able to prescribe like opioids and stuff, it's like $800. Thankfully, my program pays for it, but not all programs do. So just another important consideration.
Thank you.
All right. Any other questions? Well, I appreciate all of you taking the time to be here. I know this is not an exciting topic in and of itself, but hopefully it gave you something to think about. And like I said, if you can help educate other students on your auditions and likely help some residents out too, inadvertently, it'll make a really big difference. I've had multiple nurses where I've like talked with them about how, for example, when we're operating and they're sitting at their desk and they're facing the side like this and they're close to the patient, that lead's doing nothing for them. That radiation's coming all and just hitting them right in the shoulder, and hitting, especially the females, right in the axillary region. And so it's like a nice way where you can kind of pull someone aside and just give them a chance to like educate them. I wish someone would have told me these things, a long time ago. So hopefully you guys can pay it forward and share this with other people. But thank you all for your time, and I hope you guys have a good rest of your evening.